Okay, it's recording. So we're going to try out this program. I've never used it before. I typically use a different note-taking app to write my notes and stuff, but this seems like the easiest way to record. And I don't know how to interface my good mic, so hopefully the sound quality is good. So we're going to start with cardiac anatomy. It's kind of important to know what the actual organ looks like. I'm sure this is like super review for a lot of people, but we're going to go through the basic of it, I guess. That's already bad. So, this is a terrible heart, but it's whatever. Obviously, we have our four chambers here. Right atrium, our right ventricle, which is smaller, our left atrium, and our left ventricle, which has that thick muscular wall. And I'm leaving the top open here so I can put in some vessels, which aren't like necessarily important for this, but we'll go ahead and put them in anyway. So here's our, and this is like oversimplified in lieu of like, I don't know the actual numbers of branches and whatnot, but this is going to be our pulmonary artery, which is taking deoxygenated blood from the right ventricle into the lungs so that we can have gas exchange. And then we're going to have our oxygenated blood denoted by our pulmonary veins. I'll just put a couple on each side. Understand that these ones here on the left are actually inserting here into the left atrium. And here's going to be our left ventricle, which is the most important there. And we'll have our right atrium and our right ventricle here. And then, of course, we're going to have our inferior vena cava, our superior vena cava, and from the left ventricle, we have our aorta. First off, we have our aortic semilunar valve, and that's going to go up and create our aortic arch, yada, yada, yada. I'm just getting these in here. Aortic arch, and then our descending arch down to the descending aorta, into the abdominal aorta, to the iliacs, to the femorals, popliteals, yada, yada, and all the other systems there. And of course, these branch off into like your subclavian brachiocephalic and your common carotids, but that's not really important for arrhythmia. This is why it's hard to teach live, because I get sidetracked. So, route of blood, super easy. Into the vena cava, or vena cavae, into the right atrium. In diastole, passive filling, and some assist by atrial contraction, fill up that right ventricle, and then it shoots that blood out into the pulmonary circulation through the pulmonary arteries. Capillary action occurs here, and we have our mixing and our exchange of carbon dioxide and oxygen, as well as other things. But we're having that exchange into oxygenation, and we're having our release of carbon dioxide, and then the blood then returns from both sides into the pulmonary veins, which go into the left atrium. Again, passive filling predominantly, but assisted by atrial contraction, fill up the left ventricle. That contraction then works with Starling's law as the stretch, reception inside of that left ventricle dictate the strength of contraction, which is important in cardiac tamponade, and also in tension pneumothoraces, and also pulmonary hypertension, and yada yada. But then that blood, once the left ventricle contracts, goes into the aorta, and then diastolically it feeds the coronary perfusion, the coronary arteries, as those aortic semilunar valves close and it fills up those coronary arteries in diastole. And then during systole, it shoots blood through the aorta up into the head here, into the subclavian and brachiocephalix, and then to the rest of the body through the descending aorta. Bueno. So, making sure I'm still recording sound here. So let's go ahead and take off all... Why is my eraser not working? What? Oh, that's kind of neat. Okay. I just had to change it. So we're going to erase some of this circulation stuff because it's not necessarily relevant to the electrophysiology, but we'll just keep like bits and pieces of it for the sake of the drawing. And we'll erase our labels because hopefully at this point and before this you knew that. That was just kind of an I just read a text. Overview. Atria and ventricles, it's like EMT basic stuff, like, so, yeah. So let's move on into the electrical conduction system. So we're going to start up here in the right atrium. This is the sinoatrial node. Okay, atrial node, it's kind of easy, and that's usually noted as the SA. The SA node follows a few pathways. If you take an anatomy class or have taken an anatomy class, then you kind of know these pathways, and you'll get into the atrioventricular node. The AV node is very important. Simply, it is responsible for being the gatekeeper, the Heimdall of the freaking ventricles. So you have this like AV node, and as it is, the AV node is kind of, it has like two parts sort of. You have this like non-conducting anterior bit here, as well as the conductive inferior bit here. Superior. It might be anterior. I haven't cut one open and tested it, but superior and inferior. So this non-conductive part, essentially a stimulus hits this through these pathways and it slows the rate until it hits threshold to actually propagate that into the bundle of His and the bundle branches. So that's kind of how that works. And then when you have reentry tachycardias, you either bypass that or the AV node is defective or whatever, okay? So anyway, the AV node then tracks down into this part. This is called the bundle of His. The bundle of His. Which then, I went to eraser again, which then goes into the, oh God, I'm in the highlighter. See, this is what happens when you use a new program. The left bundle branch and the right bundle branch, and then Purkinje fibers. And this kind of explains morphology of the QRS a good amount, but when we get into fascicular blocks later on, you also have a posterior fascicle as well as an anterior fascicle here in the ventricle, which have different morphologies. So if we look at the typical sinus, normal looking, QRS or PQRST, I guess, since we're going over the whole thing, you've got your isoelectric line. Let's actually draw out like a nice isoelectric line. And this isn't notability, so it doesn't straighten out. So that's not a very good isoelectric line. Let's just get working on that. All right. So we have our isoelectric line, and we have our little stop here. Our P wave is going to be, pretty round, semi-flat. And we'll go over the actual measurements later. Then you have your PR interval. Theoretically, it could be a PQ, but your PR interval, the PRI, which typically, normal is going to be at tops, 0.2 or I think 20 milliseconds. And then you're going to have a Q wave sometimes, which is the first downward deflection after the P wave. You're going to have your R wave, which is going to be your first positive deflection after the P wave, your S wave, which comes after the R, and then you're going to come back up. You're going to have a bit of a period here, and then you're going to have your T wave. T waves are pretty important. This is the ST segment between the S and the T wave. This is your R wave, and this is your Q wave. So like some important things that we're going to go over are PRI, the QRS duration, our ST segment, and our T wave morphology, morphology. And then also your QTC or your QT interval. Then, you also go into amplitudes, and then like full QRS morphologies, that all kind of ties into like specific pathologies. So with PRI, in the basic like arrhythmia, 4 lead, 3 lead, you're going to be looking at duration. And the PRI is either going to be constant and normal, constant and long, constant and short, or varied. And the variance in the PRI you'll observe in certain blocks is going to dictate what type of block you have. QRS, essentially at the very basic level, you're going to have narrow, wide, very wide, and essentially a narrow QRS is good. Your semi-wide QRS, which is up to 100 milliseconds, is going to be like an incomplete or a non-specific atrioventricular delay. And then very wide is going to be greater than 120 milliseconds. I guess you could say greater than or equal to 121 milliseconds if you want to be like super precise. Yep. So let's kind of get into it. How do I oh, cool. I can move this stuff around. So let me pause the instruction and then we'll. So before we do specific metrics on the QRS, I kind of want to go over a quick tip for obtaining a rate on both a rhythm strip and a 12 lead, because this is so essentially if you print off a 6-second strip, or if you receive a 6-second strip, it makes it kind of easy, right? So if you have a 6-second strip, and as long as you have a pretty normal QRS, these are going to be simplified QRSs, you're essentially going to take the number of QRSs in a 6-second strip, and you're just going to multiply it by 10. Because obviously, 6 times 10 is 60 seconds, which is per minute. And then you're going to have 1, 2, 3, 4. So they're going to be about 40 beats per minute. Super simple, right? So if you have a bunch of QRSs in a 6-second strip, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, around 16. So it's going to be 160. So you can kind of, off of a rhythm strip, you can tell, is it fast, is it normal, is it slow? And then your normals, vary by person, depending on their history. But, we'll go into that right after this. On a 12 lead, because a 12 lead is, and this is really important. So one of my biggest pet peeves, and maybe I don't know something, but one of my biggest pet peeves is having somebody hand me a rhythm strip with no 12 lead and saying that someone has a left bundle branch block or a right bundle branch block or whatever. Especially the blocks, because blocks require more than one lead to actually diagnose or rule out, is the, proper terminology if you're not a physician or an APC. But it's not scaled. A rhythm strip is not scaled. So you're not going to get an accurate QRS duration, and you're not going to get accurate, you don't have the multiple views that you need to actually show a bundle branch block in a rhythm strip. So if you see, rabbit ears and a kind of wide QRS on a rhythm strip, and you try to tell me that it's a right bundle, I'm going to ask for the 12 lead. because the 12 lead is where you're actually going to see that duration greater than 120. You're going to see the RSR or the other morphologies of a right bundle. You're going to see the slurred S wave. Like this stuff is not visible in a rhythm. So don't say that you have a bundled branch block. You can say you have a widened QRS appearance on the morphology, but you're not going to be able to say like, oh, they have a left bundle. Unless they have a history of it and it looks wide, and then you can assume, but you can't definitively say unless you look at a 12. So and this is kind of where I wish I was on Notability so I could draw lines, but essentially on a 12, you have the little boxes, right? And the little boxes are comprised of smaller boxes. So each of those boxes, each of these medium boxes is representative. Once you find a QRS that lands at least somewhere near, or if you just march it out with calipers or a pen or something, then you can kind of determine this, right? So if you have this duration between QRSs, one box, that's 300. If you have it between two boxes, that's 150. Three boxes is going to be 100. And so on and so forth. 4 is going to be 75, 60, 50, 43, and 38. But essentially, I mean, you can memorize these. Like, I have them memorized, except for 43 and 38, because, like, at that point, you know they're bradycardic. Like, and you can just look at the readout on the 12 lead to get a rate. It's one of the only things you can trust it to actually have is a rate. Unless it's AFib, and then sometimes the rate is averaged and whatever. But yeah, 300, 150, 175, 60, 50, 40 something. 40-ish. So when you're looking at a 12 lead and it shows QRSs, lining up with these boxes, then you can quickly obtain a basic rate. Like, 300, 150, 175, yeah, it's about 70. And then you have a ballpark rate if you're not, busy looking up at the metrics at the top of the EKG. So, yeah, rate's important. So now let's go into our measurements. And I have this written. I'm kind of looking over my notes too, because I took all these notes from Amal Matu's EKGs for emergency and critical care. And then a lot of it was just from memory, but to make sure that everything is spot on, I'm pretty sure this is on my other EKG guide. And I have some written guides that I can give you guys, but it's not really organized. I just kind of did it on a whim. So let's do this, right? So we'll draw out a little QRS here, PQRST. And we'll kind of highlight our PR. We'll kind of highlight the important bits. And then just the P wave and just the T wave. So the P wave is supposed to be small and rounded. It's typically a positive deflection, and that's coming from sinoatrial and atrial depolarization, which the notes will go over, like dipole, repole, the electrical gradient, the chemical gradient, all that stuff. I'm not going to go over that verbatim because that's annoying. So let's write it out. So, oh God. Our PRI, our PR interval, as it's denoted, so it's either a PR or it's a PR with a line over it, or it's the PRI is the PR interval. And the PR should be between 0.12, or for you nerds out there, 120 milliseconds, to 0.22 seconds, which is 220 milliseconds. So in general, the PRI is going to be, wider than the QRS. The QRS is the most rapid dipole because it has those real fast tracks of the bundle branches and the bundle of His in a normal heart. So you have your PRI. A Q wave, Q waves are kind of case by case. There are normal Q waves, there are pathologic Q waves, and there are old infarct Q waves. And then you also have Q morphologies in different blocks and things like that. But the Q is the initial deflection, downward deflection, after the P wave. And it precedes the R wave is the kind of important part, because if there is no R wave, then that would be an S wave, theoretically. So it's the initial downward deflection after the P, preceding the R. So the Q wave, you have septal Q waves, which are, normal variants. And this is like Matu level stuff that you don't really learn this in paramedic school. But septal Q waves are essentially like small downward deflections in 1 AVL, V5, and V6. So let's change our color here, and we'll go 1 AVL, V5, and V6. And this is kind of 12 lead stuff, but we're just going over this. And this is depolarization of the septum, which makes sense. Because if you're looking at like AVL, like the augmented, limb lead left, AVL, you're going to see a negative deflection as the septum depolarizes, because it's kind of moving contrary to the average depolarization, if that makes sense. We'll go over that in the 12 lead stuff. I'm going to try to weed out some of the 12 lead stuff for this lesson, because this is just arrhythmia. Toward the right side. Yes, charge away. Pathologic Q waves. I feel like we shouldn't even go over Qs anymore. We'll go over that with the 12 lead stuff, because it's not really relevant to rhythms. R wave. So the R wave is the first, or the initial, positive deflection following the P wave. And this is because the Q wave happens circumstantially. Like, you're not always going to have a Q, so you can't always call something an R if you are, determining that based on the presence of a Q wave. It demonstrates the primary ventricular depolarization. So we'll go over the direction of the electricity, which will kind of make more sense. And each lead has a varied representation of that. So the R wave is typically heavily present in lead 2, which is our rhythm lead, because of its proximity and its direction facing that left ventricle, which is where most of that electricity is moving toward. Because a positive deflection in EKG means electricity is moving toward the lead. The negative, like, it's looking at, the lead is looking at the heart at a certain angle. And when the electricity moves toward that lead, that's when you have a positive deflection, right? So if you had a camera, and this is going to be like a terrible camera. Let's put a reel on it. Okay, so when you have a camera and something moves toward it, it gets bigger in the frame, right? If anything moves toward you, it becomes bigger focally. So that's how you can kind of understand the way that a lead is directed. A lead is looking at a certain angle, and if things move toward it, it gets bigger. So that kind of presents a positive deflection. The same way, if something moves away, it gets smaller. So you have a negative deflection. So you have a positive and you have a negative. Okay? S wave. The S wave is the initial negative deflection after the R. right? So you could have like an RS, you could have a QRS, you could have a QR. Like some of these are not present in some people, depending on what's going on. And then the T wave, I guess we can go over QRS duration. This is still like kind of 12 lead because, again, rhythm leads aren't scaled. The QRS should be less than or equal to 120 milliseconds, typically. If you're looking for like pathology, less than or equal to 120 milliseconds. Otherwise, you start looking for blocks. If it's between 100 and 119 milliseconds, then you'll consider an incomplete block of some sort. But that's 12 lead stuff, so we'll just kind of push that over there. So these are your metrics other than T. A T wave has a rounded, normally it's rounded. It follows the QRS. And it demonstrates repolarization. Repol. That's important for commotio cordis and R-on-T phenomenon and all that other nonsense. So this is the repolarization. This is like the electrochemical gradient returning to its normal, which I think is negative 20, if I'm not mistaken. What's our normal voltage? Negative 90 is the threshold. What's our normal? Yeah, so there's like a normal threshold. It's returning to a state where the ions are in the right spots and it's ready for another depolarization and contraction. So those were the numbers. So I'll pause here and then we'll go into the rhythm. All right, so let's get into our sinus rhythm, our normal sinus, and our sinus tach, and our sinus Brady. So sinus is making things super easy by saying that it's coming from the SA node up in this right ventricle. Yeah? This is the normal spot for our conduction to begin, is the sinus rhythm. Yeah? So the sinus node, or the SA node, the sinoatrial node, has a normal rate of 60 to 100 beats per minute. 60 to 100. So under normal circumstances, this thing is going to be ticking away. It's anywhere from 60 to 100 beats per minute. That would be our NSR rate. Technically, anything 100 plus with a normal appearing sinus impulse is sinus tach. Correctly speaking, if we go into SVT, there are types of SVT, supraventricular tachycardia. This is a tachycardia. This is a tachycardia originating supraventricularly, which means it's a tachycardia originating above the ventricles. So theoretically, and we'll go into junctional after this, but if it comes from the SA node, if it comes from the AV node, or anywhere in between, it is an SVT. Whether it's a reentry or a non-reentry tachycardia, technically, sinus tach at 150 is SVT, but it could be a sinus tachycardia. Yep. In the same way, so this is our tachy. Any rate less than 60 with a normal appearing P wave showing that it's coming from the SA node is a sinus Brady. And this is when you fulfill these requirements because, you could have Mobitz blocks and Wicked blocks that have a normal appearing P wave, but the PRI varies, or you have intermittent non-conduction, which is going to give you a type 2 block of some sort, or a second degree, type 2 and type 1. So yeah, there we go. Okay. So it's coming from the SA node. So this is what gives us this nice P wave. Basically, if your P wave has a normal morphology, it doesn't matter if the QRS is wide. It's like, let's say you have like a nice sharp QRS. And that's kind of wide, but like, let's say this is, less than 90 milliseconds, or 90 milliseconds, or even 100 milliseconds, or even 130. The reason this is called a sinus rhythm is because it's originating from the SA node. So if you have reason to believe it's coming from the SA node, you can call it a normal sinus rhythm, or a sinus tach, or a sinus Brady. There's no, like, people will say like, oh, well, we have a, the rhythm is not a right bundle branch block. That is the morphology of the QRS. But if the rhythm is originating supraventricularly and you have a good looking P wave, then that's still originating supraventricularly. It's still originating potentially from the sinus node or any of the other atrial foci. So there's that. So our sinus rhythm has a normal appearing P, a narrow QRS typically, and a regular T. Sinus rhythm, NSR. So you have NSR, sinus tach, and sinus Brady. This stuff is so hard to teach because it's like super back in the memory, but because like you look at it, you're like, oh, it's sinus. So you'll start getting some funky P waves when you talk about like junctionals and stuff. So let's talk about that. So we have our sinus, we have our sinus tach. So our sinus tach is a sinus rhythm with a rate over 100. Our sinus Brady is a rate less than 60, and they have those normal P waves. And then you have NSR, which is between 60 and 100. It's that sweet spot for the SA node to depolarize. Let's go to the AV junction. I always draw the AV node with two parts so that we remember that this is refractory and this is regular. Like, this is conductive. And like, just to reiterate here, the overall depolarization in a healthy heart is doing this, and then it's doing this, which is why you have an R wave and an S wave. Does that make sense? So it's going from the SA, let's get green. It's going from the SA node, we'll zoom in a little bit. It starts here, it goes here, it pauses, and then it shoots quickly down these, and then returns back up in a perfect world. Does that make sense? I hope so. So our AV node, the AV node has an intrinsic rate. Also, it's one of the backups. And the AV node intrinsic rate is from 40 to 60 beats per minute. So if the SA node fails to do its job, or it's blocked for whatever reason up here, the AV node will pick up at 40 to 60 beats per minute. It's a little slow for some people. And if it's a new onset, then you can experience some lightheadedness, dizziness, maybe even some chest pain, who knows, difficulty breathing. Like, people can become symptomatic from a junctional rhythm. Some people also live with it all the time. And that's the thing about a lot of these EKG findings, is that you have to substantiate them with clinical correlation. And all the radiologists are like jumping out of their chairs and getting happy about that because they always say to clinically correlate. Clinical correlation is the most important thing with an EKG, because if you have somebody with, diffuse ST elevation, no symptoms, they're young, it's probably benign early repul. But if their PR is, depressed and their ST is elevated, you've got that like slanting of the intervals, and they have some chest pain. Maybe it's positionally exacerbated. Who knows? They might have pericarditis, but whatever. So, junctional rhythm, 40 to 60 beats per minute normally. And the thing about the AV node, these junctional rhythms, is you can have a few things. You could have a short PR interval, right? Because it's not traveling as far. It's not depolarizing that whole atrium. So you could have a small PR, a small P wave. You could have a short PRI, like this. This is short. Or you could have a buried P wave, which is going to be like your QR, and then like this, where the P wave, like the atrial, it's called, or you could have a, and I'm going to add this before we start, we're going to have our inverted P wave, our retroactive P wave. So all of these things are saying that in this case, a short PRI, that just means that, we're coming from around up here, we're having some atrial depolarization, and then we're moving on to this bundle of His portion kind of quick, and that's causing a short PRI. In this case, our atrial depolarization is coming a bit late because it's starting, I don't know, maybe down here. It's kind of interesting. So electricity just doesn't shoot in one direction unless it's following a pathway. So like as you have this AV node and this impulse takes off, it's also going all these directions because it's a node. It's not, it's not like a road. It's more of just like an explosion, I guess. It's kind of a terrible, terrible thing. But this is still a refractory part of the AV node, which can cause some delay, which is why you could still have a positively deflected P wave, but it's just buried in the QRS, because the atria will depolarize in this case, but it's going to happen while predominantly the electricity is moving down the bundle of His and the bundle branches. That's why that might happen. And then you could have, obviously, your retrograde P wave, which is showing that the depolarization is starting in the AV node and it's actually depolarizing this way as well as, so it's depolarizing from up here, and then this is still going to depolarize the normal way, but because this is a negative direction from the camera, the rhythm lead, which is the 2 lead, which looks this way from the right shoulder, from the left hip, or the left limb, I guess, you're going to have that negative deflected P wave, retroactive. So anyway, you have all these weird morphologies. At a rate of 40 to 60, with these appearing P waves, you have a junctional escape. If it has these morphologies and it's 60 plus, it's junctional, accelerated junctional, sorry. It's accelerated. It's between 60 and 100, actually. Let's be clear about that. And then 100 plus is going to be junctional tach. And then if you're less than 40, then I suppose you could call that a junctional bradycardia. So really all you're doing when you're finding these rhythms, and not like the ACLS rhythms, but like rhythms, you're looking at what does it look like and how fast is it? That's all you're doing for rhythms. What does it look like? How fast is it? So, it has a retrograde P wave in all of them. Okay, what's the rate? 40. Okay, it's a junctional escape. It has a retrograde P wave, or it has a buried P wave with no like clear PRI. What's the rate? Oh, it's 105. Oh, it's junctional tach. You know, like it's pretty, it's very algorithmic. Like if you look at it in steps like that, it's going to be pretty easy. And while we're at it, let's really quick kind of segue into just atrial rhythms, because you can have, and this is basically, so you have wandering pacemaker and you have multifocal atrial tachycardia. Okay, so wandering versus MAT, multifocal atrial tachycardia, right? So we have reason to believe that the focus or the foci are in the atrium, or I guess even in this atria. So this is going to be our left atria, and this is going to be our right. So here's our SA node, and it creates this lovely P wave. But let's say that the SA node's kind of garbage, and it's not doing its job, but another focus has decided to kick in. So it's going to be roughly a 60 to 100 rate. You know, it could be when you have like a ton of different foci competing, that's how you get AFib, is you have this, you know, like sporadic, disorganized, irregularly irregular rate with no discernible P waves, AFib. But if you have a couple of foci that are competing, they're going to have different morphologies. So you could have like here, and then a QRS, and then you could have like here, and then a QRS, and then you could have like a biphasic, and then a QRS, and then you could have like, I don't know, like a cor pulmonale, and then like, you know, kind of looking thing like a camel hump. Then you have your, that's your wandering pacemaker. And if I'm not mistaken, if you have more than three morphologies of P waves, you have 1, 2, 3, and then they can kind of repeat, or there's a fourth one. And then you have like your normal one again, and then you have like your inverted one again. So like that's 2, and that one's 3, and that one's 1. If you have 3 plus P wave, oh my gosh, you have WAP, and if it's fast, it's MAT. Wandering atrial pacemaker, multifocal atrial tachycardia. Cool? And you can also have a consistent, you know, like if you have a kind of normal rate and you have like a consistent altered P wave, then you might just have an atrial rhythm, atrial tachycardia, which is an SVT if it's fast enough. So keep that in mind. Like these foci can come from different places, and it's not necessarily a bad thing. And it's not like a great thing, but it's, you know, probably not a bad thing. Let's go down to the ventricles. Ventricular foci, they can also escape. And it's going to be a rate of 20 to 40 beats per minute. And then the Purkinje fibers can actually also do it at like a 10 to 20, but at that point it's pretty trash. So the thing about ventricular foci creating either escape beats or escape rhythms is the fact that it's going to be ugly. Ventricular foci are not causing R waves that go down that nice clean bundle of His to the bundle branch, you know, highway, if you will. They're going to be wide because they're just kind of propagating from myocyte to myocyte, and that's when you get these wide, like 120 plus QRSs. You're going to have wide, you're going to have no P wave because there is no supraventricular impulse. It's just blah, wide. So if you have a wide, ugly QRS with no P wave, and it's going 20 to 40, you have what's called an IVR, an idioventricular rhythm. Ventricular rhythm. So 20 to 40, ugly, wide QRS, no P waves, IVR. Okay? Or ventricular escape if you want to go that way. If it's between 40 and 60 and it looks like this, you have an accelerated IVR. If it's let's actually go with 40 to 100 for an accelerated IVR. And if you're 100 plus and it looks like this might look familiar. VTAC, ventricular tachycardia. And this kind of like reverses the demonization of VTAC. Like, VTAC's obviously not good, but like some people come in with VTAC with a pulse and a good pressure and they're just chilling. Obviously their heart's not doing the greatest, right? But by definition, right, and you'll need a 12 lead to determine that this is not, you know, an aberrant conduction or whatever, but like if you have like a monomorphic VTAC like this, then you can have like your polymorphic poly. Mono, 1. Poly, multiple. So if you have, you know, if it meets these criteria, you can, you know, they have a tachycardic ventricular rhythm. No, it's VTAC, man. They have a, you know, ugly QRS, no P waves, and it's between 40 and 100. Like, that's weird. It's accelerated IVR. And if it's in the intrinsic rate, IVR or ventricular escape. The thing is when you have these ugly QRSs, please look. If you have the LifePak 15, they switch to these ugly arrows, which are, I guess, kind of cool because they're easy to see. But like, you've got, the problem is you'll look at it and it'll have this like ugly looking rhythm, and then an ugly looking rhythm, and then an ugly looking rhythm, and you're like, wow, that's gross. But then you look at the bottom and it has these cute little arrows. Those are pacer spikes, or at least that's the LifePak 15's interpretation of a pacer spike. If you have a normal telemonitor, you'll see typically these pacer spikes. So then instead of these, you'd call that ventricular paced. And if you see those pacer spikes and no QRS, what? Fail to capture V-pace. So like theoretically you would say, oh, we have a ventricular paced rhythm at 60 beats per minute with one failure to capture on the rhythm. You know, it's not rocket science. If you see a pacer and it's not capturing, it's a failure to capture. If you see a pacer and it is only making ugly ventricular beats, it's a ventricular pacer. And if you have this cool thing, put a little T-wave on there, these, it is an AV pacer, atrial and ventricular. Bueno? So sometimes you'll have an atrial failure to pace with a ventricular backup. Sometimes you'll have an AV pacer that works great. Sometimes you'll have a failure to capture on both, and you'll just see these like two lines with like a sick looking, disgusting like ventricular rhythm between them. You got to correlate these pacer spikes with the QRSs, because you can have like a failure to capture, but you'll still have these like little escape beats coming in, like trying to make sense of the world. So, and I know I personify this stuff, it's silly, but this is all the stuff we've done so far. Wow, It's really not that much. So yeah, I'll probably like keep these to an hour. So I have 10 minutes left for this lesson. So we've gone over sinus, we've gone over atrial, we've gone over junctional, we've gone over ventricular. Let's just define first what an escape beat and an escape rhythm are. So you can have a sinus pause, right? You can have your P wave, your QRS, everything's great. That's really ugly. And then you'll have a pause. I mean, let's kind of substantiate this claim first. Let's say this is a normal rhythm. And then a pretty decent pause happens, and then you have like no P wave, but like a junctional rhythm. Well, it was supposed to be right here, but it's right here. No P wave, narrow QRS, junctional, escape. Or a retrograde P, or a biphasic P, or a buried P. Junctional escape beat, unless it continues. In the same way, let's just pretend this continues down here. You have this ugly like ventricular thing, and it's like really slow, like this duration is super long. That would be a ventricular escape. Because the heart has all these these little like backup plans. SA fails, AV fails, ventricles fail, agonal. Like, you know, your Purkinje fibers are like barely making things work. So yeah, ventricular escape. This is another kind of pet peeve that I have, is you can have a PVC or a PAC or a PJC, premature. So you've got this rhythm and it's ticking away at 60, right? And one of these things, either a junctional, an atrial, or a ventricular beat, just kind of like noses its way in here early. Womp. That's a premature ventricular contraction, or technically conduction. A premature ventricular contraction. Go back. Thank you. Premature. But if it's ticking away and then there's a pause, this is not a PVC. It is not a PVC. That is a ventricular escape. There is a difference. And if you learn anything, just remember that. Don't diagnose bundle branch blocks with a rhythm strip, and don't call escape beats premature. Because semantically, it just drives me nuts. Oy vey. Okay. I'm kind of a mean person when it comes to that. So yeah, those are your like basic rhythms. We'll go into arrhythmias outside of VTAC, which is already there. We'll go into arrhythmias in the next one. Bye-bye. Oh God, it added a page.